you want to start to make some notes, and then I'll read you the scenario. Okay, so you just flip over your ECG and read out the number of the ECG.
ECG 1.
Great. So I'm just going to give you the scenario.
Okay.
So you've gone to a 62-year-old male at 04:30 hours. He's woken with central chest pain, running to the jaw. The skin is warm and dry. He's got a history of angina. He takes aspirin, metoprolol. I've got some vital signs for you. Blood pressure is 140/90. CRT is 2 seconds peripherally. He's got a respiration rate of 16. Describing his pain as 7 out of 10. So you've got 7.5 minutes to now interpret the rhythm in front of you, and then I'll ask you some questions about that.
Okay. So concerning morphologies, there appears to be some elevation and in the ST segments, and then some depression in other areas. In the ABR, we are negative, so that's good. QRS, there is a QRS complex in every lead. Our wave progression is normal. Paper speed is not written on here, but it should be 25 millimeters per second. And the frequency also not here, but should be 0.05 to 150 hertz. Collaboration spike is there, and it is 0.2 seconds. There's no time or date on here, but we've been given 4:30 in the morning. Patient information is 62-year-old male. This is a nice tidy reading. Seems to be a nice regular rate. So we can use the 1500 method. So we go. So we've got 1500 divided by 22, which is the small boxes between R waves, and that gives me a rate of 68, which is normal. It's not radial right there. P waves are present, upright, and regular. So that's a good PR interval. There's 3 small boxes, so 0.12, which is normal. That rules out any first degree heart blocks. There's a QRS wave for every P wave, which rules out higher order heart blocks. Q waves. No concerning Q waves there. QRS complex is 0.12, so that's ruling out any heart blocks. The ID normal. QT QT is right on two large boxes, or 0.8, so that's normal as well. ST segment, we've got elevation in V1, V2, V3, and depression in V4, AVR, and we can roll out the right bundle branch blocks. 1 in AVU for both positive, so that's a normal axis deviation. Because it's a male, we need elevation of 2 small boxes, or 2 mils in V2 and V3, which we've got. Could I see a posterior, just to see for reciprocal changes?
Don't have one available.
Okay. T waves here, we've got depression in V4, flattened in V1, so that's showing like ischemia. So I think we've got a STEMI, anterior septal, with an underlying rhythm, which is regular. We've got some ischemia in V4 and 1. So sinus rhythm, the anterior septal STEMI.
Okay, happy with that?
Yep.
Okay, just got a couple of questions around that now. So, would you treat this patient as a cardiac patient?
Yes, given his history, he's got a history of angina. He takes cardiac medications. He's got central chest pain, which is radiating up into his jaw, that's come on in the morning. So yeah, I would give him 300 milligrams of aspirin. We've got a good blood pressure, so if he has no allergies to GTN, we could consider that. We didn't, just depending on, we'd consider oxygen depending on his saturations. He definitely would need to be taken to ED for further investigations. You could just see if the GTN worked as to whether you gave more or whether it was cardiac. You consider with the 7 out of 10 pain, you'd get a line in, preferably in his left arm, and consider fentanyl for that pain.
Yep. Great. Okay, I'm just going to place the next one down. So again, I'll give you a minute to look through the process and then we'll start. Process, so turn to
ECG 2.
Okay, so this is a 32-year-old female who is short of breath, status 2. History is she's a brittle asthmatic with ICU admission 2 years ago. So mitral valve repair as a child, secondary to acute rheumatic fever. She denies any chest pain. The patient advises you that she knows she has a left bundle branch block. She states that this feels like her asthma. you 7.5 minutes to interpret the rhythm.
Okay, so our concerning morphologies are these big dagger waves in V1, V2, V3. It looks like there's some elevation in V1, V2, V3, V4, which could be a mimic, but carry on. AVR is negative, so that's good. There is a QRS, or the RSR waves in every lead. Our wave progression, nothing of note. Paper speed again should be 25 millimeters per second. It's not listed here. Frequency should be 0.05 to 150 hertz. That's not here either. Collaboration spike is present and at 0.2 seconds, so that's good. Time, don't believe we were given a time, and it's not listed on here. This is a nice tidy 12 lead, so that's good. The regularity is nice and regular. Therefore, again, we can use the 1500 method. So just counting small boxes between the R waves and then going to divide it by 1500. So you can go, could be 17 or 18, I'll just go 17. Equals 88, so that's our rate of 88, regular. We do have P waves present in every lead. Well, you can't see them everywhere, but they will be there hiding. They're upright and uniform. No funny shapes there. PR interval. Is 0.16, so that's normal. There's a P wave for every QRS complex, so that's ruling out any higher degree heart blocks. The PR intervals ruling out first degree heart block. QRS is wide. Approximately 0. 0.16, because it's more than 0.12, then it's considered wide. Which means that ID is also longer than 0.04, so that's increased QT. Is wide, so that's more than two large boxes, or 0.4, it's about 0.48, so that's wide as well. ST segment, we've got elevation in V4, V1, V2, V3, with no reciprocal changes. We've got no depression anywhere. T waves. RSR. So because we've got a wide QRS complex, we're going to look at the bundle branches. I think this would be a left bundle branch block because of the dagger waves in V1 and the monomorphic R waves in V6 and lead 1. Lead 1 in AVR. Sorry, lead 1 in AVF. We've got positive in lead 1 and negative in AVF. So we're looking at left axis deviation. No obvious Q waves that I can see, however this is a mimic, and because she's got a known left bundle branch block, which is this is showing, it's not going to be treated as a STEMI. If she didn't have that, then you could look at some other things, but not really needed in this case. She's also not presenting as a STEMI patient. We don't have signs of left ventricular hypertrophy, we don't have big waves in 6. Okay, so I'm going to call this an underlying sinus rhythm, irregular rate.